Spinal anaesthesia is a much used method in modern anaesthetic practice. In expert hands, this technique is also very safe and reliable. In spinal anaesthesia, the dose of the anaesthetic is small, and therefore this technique is also very useful in day surgery. Spinal anaesthesia is used mainly in surgical procedures affecting the lower body, particularly in orthopedics, urology, and gynecology. In spinal anaesthesia, the anaesthetic is injected into the spinal fluid in the spinal canal. The spinal cord extends in the adult patient to the level between the first and second lumbar vertebrae. The spinal puncture needle is therefore introduced to the level between the third and fourth lumbar vertebrae. The relative density of the anaesthetic may be hypobaric, or lighter than spinal fluid, or hyperbaric, heavier than spinal fluid. An isobaric anaesthetic can also be used. This makes it possible to guide the spread of the anaesthetic by changing the patient's position. The nurse sets everything up before the patient arrives in the operating theatre. The spinal anaesthesia pack is opened, and equipment for general anaesthesia is also set up ready as a precaution. The nurse draws up all the necessary drugs into syringes. Spinal anaesthesia can induce vasodilatation by blocking the sympathetic nervous system. In selective spinal anaesthesia, this reaction is usually insignificant. This sympathetic reaction can be avoided by giving ethylephrine. Due to sympathetic inhibition, the heart rate can also decrease, especially if the levels of anaesthesia increase beyond the therapeutic range. The antidote is atropine. With these drugs and careful preoperative hydration, it is possible to prevent an acute blood pressure drop caused by vasodilatation. An intravenous cannula is inserted to gain access to the systemic circulation and to allow correct hydration by administration of intravenous fluids. The World Health Organization pre-operative checklist is read by the staff of the operating theatre. This checklist has been developed to improve the patient's safety, and the list is read before every anaesthesia or any other procedure. The patient's notes, particularly with reference to their previous medical history, medication, allergies, and fasting status, are double-checked. The completed anaesthetic and operative preparations, and also the operative and anaesthetic risks, such as hemorrhage or difficult intubation, are noted. Completing the checklist takes only a few minutes, and it has been shown that it reduces complications by as much as 30%. Moreover, it ensures that the staff are more involved and engaged in the procedure. The operative area is cleaned extensively from the scapular level to the buttocks to avoid any contamination of the gloves or the equipment. The cleaning is done from up to down and at least twice. The first area washed will be considerably larger than the second. The nurse hands the opened ampule of the anaesthetic to the doctor and states the name, dose, and expiry date of the drug clearly. This helps to prevent incorrect medication. Spinal anaesthesia is carried out in such a way as to maintain the sterile conditions of surgery. The operative area is covered with sterile drapes, and the anaesthetist uses sterile gloves and a surgical mask. The nurse assists the doctor if needed. The anaesthetist feels with his fingers the correct puncture site in the area between the third and fourth lumbar vertebrae. He asks the patient to draw their knees up to their chest and to stay totally motionless. The anaesthetist also warns the patient prior to introducing the needle, informing them it will feel sharp, and asks him or her to indicate if there are feelings similar to electric shocks in their legs. These feelings would indicate that the needle has hit a nerve. In this case, the position of the needle must be corrected, even though spinal fluid would be dripping out of it. If there are no electric shocks, the needle is in the correct site when the spinal fluid is dripping out of it. The anaesthetist confirms the needle is in the correct space by drawing up the spinal fluid into a syringe. The anaesthetic is injected very slowly, avoiding any turbulence. Injecting can cause a warming effect in the legs, and the patient must be informed of this. The doctor will say clearly when he is withdrawing the needle. The patient is positioned so that the anaesthetic will spread only to the pre-planned area. After about 5 minutes, the anaesthetist tests the level of the anesthesia. With an alcohol-soaked pad, he wipes first a non-anaesthetic area like the hand, and after that the planned anaesthetic area. In spinal anesthesia, the skin's sense of heat and pain disappear, while the sense of touch remains. After testing, the doctor records the levels of the anaesthetic in the patient's notes. If the anesthesia is insufficient for the planned surgical procedure, the options are further spinal anesthesia or general anesthesia. In this case, the spinal anesthesia is sufficient, and preparations for surgery can be continued. The duration of the spinal anesthesia depends on the concentration of the anaesthetic in the planned area. The smaller the area, the less anaesthetic will be needed. After the procedure, the patient is monitored in the recovery room.